My question for all the speakers: how frequent you will end your case with double stent when you do your URS? Is it mandatory in each case, or you can skip some cases? And if you want to skip some cases, what is the indication? Using double stent possibly in each case.
Yeah, as regards the double G stent, I think double G stent they post BCNL when indicated. If there is a trauma, if there is a bleeding, if there is a possibility of residual stone, if there is infection, with indicated, not on all cases.
You mean in PCNL or ureteroscopy?
URS. You will end the case by double stent, or you can skip some cases. For example, or just.
It depends on the stone size and the time that I spent doing the ureteroscopy and evaluating the ureteroscopy after I remove the urethral access sheet. Most of my cases I use urethral access sheet. So if I have a prolonged procedure, definitely I'd like to put the stent poster.
Hassan?
Yeah, I would agree with that. I mean, practically speaking, I do use double G stents on most of my cases, often because they're more complex to begin with, larger stones, procedures not elsewhere, as an example. But I would agree. I mean, the literature, I think, is pretty clear on this one. If it's a small stone burden, you're effectively fragmented. If you dusted and you're happy with the size of the fragments, there's been no ureteric injury, you haven't used an access sheath, there's no risk of infection, negative urine culture pre-op, then I think many patients, we can avoid a stent and avoid the morbidity that we all know is associated with the stent. So I think generally speaking, stents are probably overused, quite honestly. I think the literature has shown that you can definitely do without them if you choose the patients correctly.
I agree with my colleagues. For my PCNL, I use the European guidelines with the level 1B evidence that doing a tubeless in a high volume center with no stent and no nephrostomy tube is safe. What I've been doing is doing a nephrostogram at the end. If I see the contrast going down and I see no extravasation, I remove my sheath, keep the guide wire. Then if there is no bleeding, I put a ureteric catheter, pull the guide wire so I do not slice cheat the ureter or the kidney, and do it tubeless. If I'm in a setting of a private institute where I have lack of residents and people helping me around, I keep a nephrostomy tube. As Hassan has mentioned, it's this written, and I clamp. I don't clamp. I used to clamp when I was a resident, and I remove it next morning.
I totally agree, especially regarding, you have a big experience in using ultrasound. For me, myself, I don't use ultrasound in puncture. As you mentioned, if the pelvis is facing posteriorly and you have good parenchyma in front of you, this is a good reason to do the puncture. Otherwise, you have to go to the other way. Regarding the stone fragments, as we mentioned, I think the main difference between TFL and Holmium laser, or a high-power Holmium laser, is the quality of the dust itself. So, because in TFL, you have, even for the short pulse, it has a long duration. So you can use the short pulse in TFL to produce those fine dusting. I don't think it's a matter of timing. And maybe, if you have a good irrigation, smaller ureteroscopes, better access sheets with suction, it can change the guidelines in the future that you can manage larger stones that you used to manage with PCNL, either in normal kidney or abnormal anomalies.
I have one question regarding follow-up policy after PCNL surgery to ensure stone clearance or stone filling. Do you request CT scan every case, or in some cases, and after how long?
I think in this era we try to avoid subjecting the patient to unnecessary radiation. We always teach for LR as low as reasonably achievable, especially if you deal with pediatric population. I think combining ultrasound and a plain KUB. Now, in the presence of uric acid stone, you probably need an ultrasound and make sure that you achieve medical treatment with urine alkalinization. Early in my experience, I used to do routinely CT post-op to make sure I've done a good job, but I would probably treating myself more than the patient. Nowadays, I try to protect the patient, so what I do routinely is KUB and renal ultrasound. The definition of stone-free rate in the literature is looking at 3 months. So I usually would see a patient in a couple of weeks post-op to counsel him about the stone type and see if I need to remove my stent. Most of the time I would know if I need to do for a second ancillary procedure or not by that time. So in rare cases that I will need to do a CT scan, in very difficult cases, but in that time where I counsel the patient about his stone type, I will see him with a KUB or renal ultrasound if I was happy that I was stone free. Otherwise, post-ureteroscopy, the patient will get stent removal after my initial happiness of how things went. That's my practice.
I think as regard the post-operative follow-up post-BCNL, it depends on the initial size of the stone. For stone 2 centimeters, 3 centimeters, I think you are not need more than ultrasonography after 2 weeks. But for staghorn stone, multiple stone, you can tell your patient from the start this is a very huge stone burden, especially in hard stone, and mostly you are need for stage or for you will need for a second session, whatever, Shabir, strepsy, flexible, even another session of BCNL. In this complicated or complex cases, we are in need for CT. But for simple cases, ultrasonography is very sufficient after 2 weeks.
First of all, I would like to thank the speakers for these wonderful tips and tricks in endurological maneuvers. My question is for Dr. Hassan regarding the heating effect or the thermal effect of laser on the kidney. Why I'm asking this, because I passed through this experience recently with 2 patients. We don't have TFL in our unit. We have holmium laser, and we are using most of our cases without ureteric access sheath. So we encountered just strange difficulties in accessing the middle and lower calyx in the patients after fragmenting the stone in the upper calyx. When we discussed this with one of our colleagues, we are using high energy and high frequency without access sheath, and we stayed quite good time. So the only explanation that there was like a burning effect on the mucosa, and it was difficult for us to get into the middle and lower calyx at the end of the procedure. So I think this is the only explanation. It might be correct, it might not be, but I think we need to pay attention to the thermal and heating effect of the laser on the kidney, especially if we are dealing with large stone and without ureteric access sheath.
Yeah, to bring up a very good point. I mean, I think the issue of the temperature is not something that typically was talked about much with the holmium laser, but with the thulium fiber laser, there's been this conversation about when is the heating potentially dangerous. But I think there probably are many cases that holmium gag as well has probably led to some thermal effect. And I think some of the key points you've raised here, number one, is it with an access sheath or without? I mean, clearly without an access sheath, you might be creating higher energy that's not being dissipated. That means it increases temperature, so there's a risk. The type of irrigation you're using as well probably is important as well, right? Is it just gravity? Is it some kind of handheld pressure device? Because you're going to get different temperatures anyway. So this is something that industry has picked up on, in fact. So I think most of you know that there's a disposable laser that now is going to have a pressure measurement attached to it. Well, Boston Scientific, that makes that device, has also told me they're looking at adding a temperature measurement probe as well, because I think they're seeing that there probably is some potential effects, not just with the thulium, and it may have some effects on the scopes as well as the patient. So I mean, there's a number of reasons why we probably should be a little cautious about this. So I think you're right. I think we haven't talked about it. We are now, and I think that's a good thing.
stones in this condition is not only to take out the stone, because the high recurrence rate because of anatomical abnormalities. So why did we don't consider to correct the anatomical defect in these anomalies? Otherwise, after a couple of weeks, the stone may come back again.
Actually, regarding the pathology, not all the cases have a UPJ. The high insertion itself sometimes causes this problem of the drainage. So even if you cut the isthmus, you wouldn't fix the problem, because the main problem is the high insertion of the ureter. You have the ureter up there, and the rest of the renal pelvis is down there. So it's a matter of drainage. If you have like a UPJ obstruction, you would definitely fix it. But otherwise, you still have the matter of stasis in that. I don't remember a figure, exact figure.
Okay, Professor Wael, most bureau cases I saw, the stone is not staghorn, they are around 2 centimeters. Why you don't use mini-berg rather than using standard bridge sheets 24, 26?
Sometimes some cases are very old, like that we punctured the lower calyx, they branched in the lower calyx 10 years ago. So we didn't begin the mini-berg in this year. This is the first point. As regard the difference between mini-berg or the standard, this is still a debate. Mini-berg means high intrarenal pressure, means not an infected kidney because dissemination of the infection, means more disintegration, means if there is a complication, bleeding is a debate. I still prefer the standard one, maybe 24 or 22 according to the size, to be very rapid to finish the case. This is still a debate to have. We have in the last Amsterdam EOA debate, mini-berg standard or micro-berg is still a debate. For me, I prefer standard, very rapid, saving the time. And even there is no significance in the bleeding. Sometimes there is bleeding, but the parenchymal injury last study by Traxer and only 24 is safe.
You are putting molecular tube, not microscope.
How to exit according. I put only a plastic caster, a Snelton caster, 20 French, and the size is not a matter. Close it till the morning, and the hotel caster is removed in the second day, and then first week.
Thank you very much, Dr.
Okay, so last question for me. Okay. Thank you very much for those very nice talks. And just the last question, which is straight ahead question. Dr. Hassan Razvi and probably Dr. Singh as well can give us his thoughts about this. If I have like a high power polyimide laser in my unit, should I go for the TFL now or should I wait more clinical studies?
Yeah, if you've already got a high-powered homeomiag laser and you're comfortable with it, I think you've got a very good tool and you stay with it. I mean, I don't think the data to date would suggest that you buy a new laser to replace that. If you don't have a high-power homeomiag laser, though, and you're considering, tackling more complex stones, then, perhaps you do want to consider the fluid laser. But, they're both very good tools. At the moment, the data would say the differences are very minimal, and so that would be my advice.
So I would say if you have a high-powered holmium laser with Moses, you have a good machine which can compete with TFL. But if you don't have the Quanta system with the vapor tunnel, etc., or the Moses technology, then TFL is probably a better tool. If you have a standard holmium laser, TFL is going to win hands down. Important thing is that back home in India, the cost differential between TFL and Moses is a world of a difference. To give you a sense that a TFL machine would cost something like $1 lakh or less, and the recurring disposable cost is minimum because I can re-sterilize the fiber and use it and it works for a bit. Whereas the Moses is exactly double that. The cost of the machine, the Moses 2, the luminous 2.0 version, was about $2 lakh and the recurrent cost of a fiber was about $1,000. So the cost differential, at least back home in India, is great. Where in the northern part of America, North America, the cost differential is not that much. Therefore, we
don't see that much value in